This is the final video on fever and rash. Today we will discuss the pustular, urticaria-like and nodular eruptions. First of all, let's see what a pustule is. As you can see from the name, pustule will contain purulent exudate and it will have a erythematous base. Nodule will always be associated with fungal infections. So think of fungal infections when you think of nodule. This is a brief overview of all the dermatological conditions we have seen so far. A macule and plaque, these are flat, while papule, nodule and pustule are always raised. Papule, plaque and nodule can be differentiated from their sizes, as you can see here. Wheals, which we commonly see in urticaria or even in tuberculosis skin tests, these are basically papules or plaques. Ulcer, what the important thing you need to remember is it involves the dermis and the epidermis. So first of all, we discuss varicella, which causes chicken pox. The patient will present with low-grade fever and rash. The rash is the most important thing you need to remember, and the diagnosis is also made on the basis of the rash. There are three stages. You will see maculopapules, vesicles and scabs. The most important thing is that you will see these stages simultaneously, meaning that in this image you can see that these are maculopapules, while these enlarged bodies are vesicles, and scabs are not clearly seen in this image. Then the rash will first appear on the trunk, then it will move on to the face and then on to the extremities. So the distribution should also be remembered. As you can see, there are erythematous bases. New crops will keep on coming as the infection progresses. The duration is limited to 6 days and the infection is self-resolving. So the treatment will only be symptomatic if the patient is immunocompetent. Bacterial superinfection is a special case seen in immunocompromised patients like HIV, AIDS, etc. So there the patient will present with cellulitis or impetigo. CNS involvement is also seen in children, and you will see encephalitis, and that is also a case of immunocompromised state. So herpes zoster is a infection caused by varicella, but due to the reactivation of the varicella zoster virus. So what happens is varicella zoster virus first enters the nasopharynx. That is, it spreads via the respiratory droplets or via vesicular fluids, but respiratory droplets is more common. Then it enters the nerves and it travels through them and it stays latent in the dorsal root ganglion. This happens in the initial infection, which is chicken pox. However, when even after the chicken pox has resolved, it stays latent in the dorsal root ganglion, and if the patient is immunocompromised, it will get reactivated and it will cause herpes zoster, which is also known as shingles. It is so because it occurs mostly in immunocompromised patients. The age group will be more than 60 years. Now let us talk about the rash. It will be present unilaterally. This is very important. It is important for diagnosing the patient, and you will see a typical dermatomal distribution from T3 to L3. In this diagram, have a look at the diagram. This is T3 here and this is L3. So you will see unilateral distribution of rash between in these dermatomal regions. Also, the pain will be described either as a throbbing pain or burning pain. The varicella zoster virus also infects cranial nerves, and if the trigeminal is involved, it will present as herpes zoster ophthalmicus, and you will see typical dermatomal distribution of pain, and patient will present with blindness. If the facial and glossopharyngeal nerves are involved, then as expected the patient will present with hearing loss, and this condition is known as herpes zoster oticus. Now we have Pseudomonas. This is a relatively easy topic. If a patient has a history of hot tub bath or of swimming in pools, then you should think of hot tub folliculitis, especially if the gram stain and other characteristics resemble Pseudomonas. Now, ecthyma gangrenosum is seen in immunocompromised patients, and it is a disseminated infection which involves the dermis. First, you will see macules in ecthyma gangrenosums, which will progress to pustules, and then you will eventually see ulcers. So this is all about Pseudomonas. This image is not required, just the history of hot tub bath or swimming pools should take you to hot tub folliculitis and then answer whatever question is asked. Let us first discuss the pathophysiology of a herpes simplex infection that will help us in clearing most of the points we need to know. What happens is that HSV infects humans via either the mucosal contact or via contact of the dermal lesions, as you can see in this image. So once the virus has entered the body either through the mucosa or the dermal lesions, it will invade and spread via the nerve cells, and via nerve cells it will end up in the ganglions, and there are two ganglions which the HSV infects. One is the trigeminal and the other is the sacral. Now, once it has reached the ganglion, it will stay latent here. Once, if the patient is immunocompromised or undergoes a condition of stress, this latent infection will be reactivated, just like in varicella. So now let us discuss the differences between HSV1 infection and HSV2 infection. I like to think of HSV1 versus HSV2 as HSV1 infects everything above the waist and HSV2 infects everything below the waist. HSV1 infection will be a labial infection. That is, it will affect the lips. HSV2 will infect below the waist, so it generally causes genital lesions. This is a genital lesion. The other signs and symptoms you will see in case of HSV1 infection are vesicles in the lips, and in HSV2 infection you will see painful red swollen lesions in the genitals, and also you will see painful lymphadenopathy. So this is all about herpes simplex infection. The things you need to remember is that it travels via the nerve cells and that it stays in the trigeminal ganglion in case of HSV1 infection, and in the sacral ganglion in the case of HSV2 infection, and that it is reactivated in immunocompromised state. It affects the labial mucosa in case of HSV1 and the genitals in HSV2, and that closes up herpes simplex. Rickettsialpox is seldom seen in exams, so we will go through it quickly. It is most commonly seen in urban settings. You won't see it in rural areas. There are two types of rashes you will see. First, vesicles will appear, which will contain fluid, which will move on to purulent exudate containing pustules. You will get a history of rat bite, which makes the diagnosis pretty clear. You may confuse it with varicella, which causes chickenpox. If the patient has a eschar, in this image you can see that this is an eschar. You won't see a eschar in the varicella infection, and also you will see a papule or a plaque base in case of Rickettsialpox infection, while if you remember in varicella infection you saw maculopapule or vesicle or scab. So this is all about Rickettsialpox. Remember rat bite, and also remember how to exclude varicella, and it will get you through. So urticarial vasculitis is the second last topic for today. The first thing you will need to do in case of urticarial vasculitis is to rule out urticaria. Now, how will you rule out urticaria? First of all, urticaria stays for a matter of hours, say 24 hours. However, urticarial vasculitis will be present for 3 to 5 days. So this is the first differentiating factor. Also, another important one is fever. Urticaria will never have fever, but urticarial vasculitis will have fever. So these two will help you rule out urticaria. Now, there are a couple of associations you need to remember. This will be mentioned in the question stem, and these will help you to reach to the diagnosis of vasculitis. Serum sickness caused by sulfa drugs or penicillin or salicylate drugs will be seen. So these drugs can cause urticarial vasculitis. Patients with SLE or Sjogren's syndrome, they are at risk for urticarial vasculitis. So look out for patients with this kind of history. Another a very important association is lymphoma. Patients with lymphoma can have chronic urticaria, which will also have fever. So lymphoma is a pretty important one. The last topic for today is nodular lesions, and as I mentioned in the start of the video, nodular lesions should remind you of immunocompromised state, disseminated infection, and these are generally fungal infections. So let us go through these one by one. The first one is candida, and you will see a triad of fever and with muscle pain and nodules. So if this is the presentation of the patient, think of candida. Cryptococcus infection will resemble infection by molluscum contagiosum, and I will be making a separate video on this topic, so stay tuned. Aspergillus and mucor infections will present with a necrosis of the nodules. If you see necrosis of the nodules on the physical examination of the patient, think of aspergillus or mucor. Sweet syndrome should be considered in individuals where you see multiple nodules or plaques, and they will be very edematous, even so much so that they will look like vesicles. Sweet syndrome is seen in patients who have inflammatory bowel disease or who have some malignancy or who have taken some specific drugs. Now let us look at the images. This is a typical uh, fungal infection rash, and this will show you that the infection is disseminated. These are all disseminated infections of fungus, and this is a nodule. These are nodules. So this brings us to the end of this video. Hope you find this useful. See you.